Good morning. My name is Nancy Dunn Thompson, and we're at the Elizabeth McGowan Training Institute this morning and filming for mmlearn.org. This is part of our Ask the Geriatrician series, and we want to start by thanking the Baptist Health Foundation of San Antonio for their generous support, which has made this filming and our other videos in Ask the Geriatrician possible. We also want to thank the Methodist Healthcare Ministries Foundation, the San Antonio Area Foundation, the Prior Trust, and the many other organizations and individuals who have supported the mission of mmlearn. Now, we want this to be interactive, and we have such a special guest with us today. We want you to be sure and send in your questions, and you can do that in two ways. If you're joining us on the internet and you look at the top of the screen, you're going to see the Ask bubble. It reminds me of a comic bubble. If you click on that, you'll be able to send an email to us, and we'll give that to Dr. Raji, who will respond. If you are listening by phone or for some reason cannot send an email, you may also phone in your question to area code 210-264-7000. Dr. Raji is the professor and director of internal medicine and geriatrics at the UTMB Medical Center in Galveston. He's also the program director for the Geriatric Fellowship, and he's with the Department of Internal Medicine and the Division of Geriatric Medicine. I also understand that he's a very kind and gentle geriatrician, which I found all of them so far to be. So we're very lucky to have him here, and please send in your questions, because not often will we have someone with such a tremendous background to respond to our questions about transfer trauma. Thank you very much, and Dr. Raji, welcome to mmlearn.org.
Thank you. Thank you for such a great introduction. My name is Mukaila Raji, and today we are going to be talking about transfer trauma and how we can reduce constant trip to the ER, because emergency room is not a safe place for seniors. I'm going to start this talk by talking about some of the consequences of frequent emergency room visits and rehospitalizations. The number one consequence is increased exposure to infections, especially flu, Clostridium difficile diarrhea, methicillin-resistant Staphylococcus aureus, bed bugs, lice, and visit to emergency room and hospital recurrently can also increase the risk for bed sores, falls and fractures, high risk of drug toxicity, delirium, especially in patients living with dementia. Then there are complications from procedures that you get when you go to hospital recurrently, from bladder catheter, intravenous administration. Recurrent hospital visit is not cheap. In 2004, it cost Medicare $17.4 billion. It creates stress to patients, family, and nursing home. And this does not even include the common occurrence of loss of property, including dentures, glasses, hearing aids, wallets, canes, and so on and so forth. Now, if we are going to reduce recurrent hospital visits by senior citizens, we need to answer two questions. How common are recurrent emergency room visits? What are the most common medical diagnoses accounting for recurrent admission in the elderly patients? Published research in the New England Journal of Medicine shows that 20% of Medicare patients discharged from the hospital will get readmitted within 30 days, and 34% of them in 90 days. The common top medical diagnosis for readmission as listed in this slide: congestive heart failure, pneumonia, chronic obstructive pulmonary disease, psychosis, gastrointestinal problems, and especially medication poisoning. It is important to know the content of this slide because this will begin to guide us in developing and implementing programs to reduce recurrent hospital transfer in the elderly population. Now, I will say a few things about medication use that lead to emergency department visits. The reason this is important is because this is potentially preventable. A study in the Annal of Internal Medicine, 2007, showed that among seniors with multiple emergency room visits to U.S. hospitals, 3 medications account for 1/3 of these visits. What are these medicines? Warfarin, which is used to prevent stroke in people with atrial fibrillation, insulin, which is used for diabetes, and digoxin, which is used for heart failure and to control cardiac arrhythmia. By knowing this, we can begin to look at how we can develop programs to prevent drug toxicity related to these 3 drugs. Specifically, among the nursing home residents, the commonest diagnosis for acute hospitalizations and emergency room visits are urinary tract infection, pneumonia, and congestive heart failure exacerbation. Acute hospitalization and ER visits in nursing home residents in various studies has been shown to be reduced when patients and their families inform the nursing home staff about their preference for do not resuscitate orders. We also do know that weekend and evening night shift in nursing home is associated with increased likelihood of hospitalization for urinary tract infection. This information begins to guide us how we can design systems to reduce recurrent emergency room visits. Now, it's important to recognize barriers and challenges to treating acutely ill residents in the nursing home. By recognizing these barriers, again, we can begin to design systems to remove them. Difficulty in obtaining antibiotics quickly. Poor documentation of resident wishes for hospitalization. Insufficient staffing, and especially high prevalence of dementia in the nursing home. Some of these lead to defensive practices by doctors and nurses which erode the autonomy of the practitioners and can potentially compromise patient quality of care. The other challenges we have in nursing homes are limited access to biotechnology and immediate testing to allow us and to guide us in choosing the right treatment. Equally important is the unusual presentation of illnesses in the elderly population of nursing home. Then there are family, ethical, legal, and regulatory concerns which make it complex and complicated for physicians and nurse practitioners to practice evidence-based medicine in nursing home. Many people would choose different treatment because of these concerns. Again, this can reduce the autonomy of the clinicians to choose the evidence-based medicine. So, having shown you the severity of this condition of recurrent hospitalization and some of the challenges that we face, I will now show you evidence from published research of what we can do to reduce frequent